We're going to start the mini symposium today, the Human Reproduction Symposium. So my name is Christy Adamo, and my esteemed colleague here, Jacob, we are going to be co-chairing this. But I kind of have the lead. I'm the Pat Sajak. He's the Vanna White, for those of you who are of an age that would understand that. So I have the great pleasure of introducing three speakers who I actually know quite well and I collaborate with quite extensively, so this is kind of exciting for me. The first of our speakers is from the University of Alberta, and it's Margie Davenport.
Okay, great. Thank you very much. Nice to be here. I'm an associate professor at the University of Alberta in the Faculty of Kinesiology, Sport and Recreation, and I'll be talking today about prenatal physical activity. I have nothing to declare. If you're not already aware, pregnancy is associated with some pretty profound and rapid adaptations over the short 9 months of pregnancy, including an increase in insulin resistance, an increase in resting ventilation. Blood volume is up by 50% and cardiac output by 30%. Some of the other really normal, healthy adaptations to pregnancy is weight gain. So all women are recommended to gain weight during their pregnancy, and this is to account for the growing fetus, the placenta, but also the extra blood and fluids and protein that are going to build up over the course of pregnancy. Although women are recommended to gain weight during pregnancy, the Institute of Medicine has developed gestational weight gain guidelines, which are based on a woman's pre-pregnancy body mass index. However, it turns out that more than 50% of all women will exceed these recommendations during pregnancy. And we do care about this because excessive weight gain during pregnancy is associated with a number of different pregnancy complications, such as gestational diabetes, hypertensive disorders of pregnancy, cesarean delivery, and then for the baby, they're at increased risk of being macrosomic, which means that they have a birth weight over 4,000 grams or 9 pounds. But why do we care about this? I mean, pregnancy is a really short period of time, but it turns out that these physiological stressors of pregnancy are actually a stress test for life, and they can, the development of pregnancy complications may actually predict future chronic disease risk for both mother and the baby. So for example, women who gain an excessive amount of weight during pregnancy are at 2 to 4 times increased risk of developing overweight or obesity or postnatal BMI increase over their lifespan. Women who develop gestational diabetes are 5 to 7 times more likely to develop type 2 diabetes than women who did not develop gestational diabetes. And women who develop preeclampsia are 2 to 4 times more likely to develop cardiovascular disease. In terms of the baby, babies who are born over 4,000 grams have been shown to be at increased risk for developing childhood obesity. So for example, this meta-analysis, which was done a number of years ago now, demonstrated a 66% increase in the risk of having overweight or obesity in childhood. And other studies have suggested that this relationship actually persists into the adult years, and some studies have even suggested that the relationship between high birth weight and higher BMI actually will persist right into the later years as well. So what can we do? Is there any way that we can intervene and somehow prevent chronic disease risk for the future health of 2 generations? Now, I'm an exercise physiologist up front right away. Guidelines across the world recommend that women exercise throughout their pregnancy. I put Canada on top because our guidelines are the best, right? And this is because of there are a number of really important maternal and fetal health benefits to exercising during pregnancy. So here in Canada, we recently released the 2019 Canadian Guideline for Physical Activity throughout pregnancy. I'll touch on a few of the guidelines and recommendations today, but if you are really interested in it, you can go to csep.ca to see the guidelines that are available. They're public-facing, so they're very easy to read. The documents themselves, less so. So this new guideline was developed over a 3-year process. I was the chair of the guideline consensus panel. Michelle Matola in the audience was my co-lead with Stephanie Ruchet. Christy Adamo was my moral support, and Tanya, somewhere in the audience as well, was the representative for Exercise as Medicine. Really important process. We had researchers, methodologists at the table, but critically, we also had all of our stakeholders of individuals who work with pregnant women, so our clinicians, exercise professionals. As part of this process, we developed 12 systematic reviews. It was a big process, which is why it took so long. We reviewed 28,000 titles and abstracts, and in the end, we included 675 unique studies. I really want to highlight these women here. There were 12 of them who did the bulk of the work, and we take all the credit. The systematic reviews were published in 2 editions of the British Journal of Sports Medicine in the last few months. So the first recommendation that we had is that all women without contraindication or a medical reason why they should not be active during pregnancy should be physically active throughout their pregnancy. Now, we specifically looked at 3 different subgroups because there had been long-standing questions about whether or not it was safe and beneficial for certain women to be active during pregnancy. So, for example, women who were previously inactive, women with gestational diabetes, and women who are categorized as being overweight or obese prior to pregnancy. The results of our meta-analyses demonstrated that it is both safe and beneficial to exercise from conception right up to delivery. There were lots of benefits identified, and we did not find any adverse effects. We did look for them. All of our evidence that I'm providing today is based on randomized controlled trial evidence, exercise only. We did look at other interventions as well, but I won't be talking about those today. So the results of our meta-analyses, exercise-only randomized controlled trials, found that women who exercised during pregnancy had a 32% reduction in the risk of developing excessive weight gain during pregnancy. We also found that women who exercised during pregnancy had a 39% decreased risk in developing macrosomia, or birth weight over 4,000 grams. Now, I presented suggestions that women or babies that are born over 4,000 grams might be at increased risk for developing childhood obesity. Unfortunately, we couldn't look at the impact of reducing macrosomia with prenatal exercise. There's very little evidence out there at this time, but I know that there's a number of groups that are working on this right now. Prenatal exercise had other benefits as well. There was a reduction in gestational diabetes, gestational hypertension, and preeclampsia. The reduction was about 40% in women who exercised compared to women who did not exercise during pregnancy. Depression was reduced by 67%, and moderate reduction in severity of depressive symptoms as well. So it was a very well-rounded intervention. But importantly, we know that many women don't exercise during pregnancy out of fear that they might have a negative impact on the baby. And so importantly, we also found that prenatal exercise was not associated with an increased risk of miscarriage, preterm delivery, or small for gestational age baby. So we have very strong evidence that exercise is safe, it's beneficial, and for both the mother and the baby. Now, our second recommendation was pregnant women should accumulate at least 150 minutes of moderate intensity physical activity each week to achieve clinically meaningful health benefits and reductions in pregnancy complications. Now, the statistician Nick and I spent about 6 months developing these dose-response equations, and we came up with that 150 minutes, the same as adults. But what we did is took a dose response between an increasing volume of activity and related it to different pregnancy outcomes. As a panel, we set a threshold of a minimum 25% reduction in the risk of developing a certain pregnancy outcome. And the results of our study actually found that there were 5 outcomes that had a dose response where if you increased your physical activity, you had a decrease in these particular outcomes. So we found this dose response with gestational diabetes, preeclampsia, gestational hypertension, prenatal depressive symptoms, and excessive gestational weight gain. Now, I want to highlight that this 150 minutes actually comes from the prenatal depressive symptoms. So you get a minimum 25% reduction in each of these 5. But one of the key takeaway messages from this is that to get, if you exercise at a lower volume or lower number of minutes per week, you can still have substantial reduction in other complications. So for example, women who exercise for 106 minutes per week still were able to get a minimum 25% reduction in the risk of developing excessive weight gain during pregnancy. Our third recommendation was that physical activity should be accumulated over a minimum of 3 days per week, but we do encourage activity over every day of the week as well. So we again did a dose-response relationship, looking for a minimum 25% reduction in the odds of pregnancy complications. So that minimum was 3 days per week. But the higher the frequency or the greater the number of days that we had activity, the greater the benefits. We also looked at the type of activity. I really want to highlight that the majority of the studies that we looked at were primarily aerobic exercise. Most of them were actually looking at walking. There was very limited evidence looking at other types of activity. But in the evidence that we did have, we found that there was some additional benefit of adding resistance training. As an exercise physiologist, we know that resistance training in general is a very important component of physical activity. And so we recommend that pregnant women incorporate a variety of aerobic and resistance training activities to be able to achieve greater benefits. We also suggest that women consider adding yoga and gentle stretching for mindfulness and also to maintain flexibility throughout pregnancy, but that is not included in the 150-minute recommendation. Now, when we talk about different ways of achieving activities, especially aerobic ones, we always think about walking and swimming. But it turns out that moderate intensity exercise can be achieved by doing everyday tasks, vacuuming, if you're doing heavy vacuuming, heavy gardening, shoveling and raking. So there are other ways that we don't typically think of as being exercise to be able to incorporate moderate intensity exercise throughout the day. So I often hear from clinicians and different professionals that I don't have a lot of time to be able to counsel about exercise. I have a 10-minute period to be able to talk to my women about all sorts of information. But if you only have 1 minute, I would recommend that you say women need to, or are recommended to accumulate 150 minutes of walking spread over 3 or more days of the week. Now this can be 30 minutes of walking 5 days a week, or just go out for a 10-minute walk after dinner or lunch and dinner every day. And this will result in the reduction in the odds of major pregnancy complications by at least 25%, and it does not increase the odds of having a miscarriage, preterm delivery, or a small for gestational age baby. Okay? Very short, very quick, and it gets the message across. But many women, we know that only 15% of all pregnant women are actually sufficiently active to be able to achieve these 150 minutes per week. And many women have not been active before they became pregnant. And so in terms of the recommendations of what women can do to begin activity if they weren't exercising before they were pregnant, we recommend just start low, go slow, do a gradual progression towards that 150 minutes. Okay. Remember that even below these recommendations, being physically active can be quite beneficial. So for example, just going out for a 10-minute walk each day can reduce the risk of developing preeclampsia, which is high blood pressure during pregnancy, by 25%. This is huge. Bump that up to 15 minutes per day, and you can reduce the risk of developing excessive gestational weight gain by 25%. Every minute counts. Okay? And so being active at any amount is better than not doing anything at all. Now, we actually developed in my lab a very brief 5-minute video about prenatal exercise, which covers a lot of the background information as well as some recommendations on how to begin exercise during pregnancy, why you would do it. It's available in English, Spanish, and Mandarin. I finally found somebody who speaks better French than I do, and so the French version is coming quite soon. CSEP has also developed csep.ca/guidelines, where you can get the public-facing version of the guideline itself. We've also developed some infographics and really short explainer videos about the importance of exercise during pregnancy. But I also really want to highlight that these new recommendations are based on the voluntary offering of their information about exercise during pregnancy, and so without the donation of many hours from thousands of pregnant women, we wouldn't know how beneficial physical activity would actually be. Okay. Pass? Oh, sure.
Thank you very much, Margie. So we're actually going to ask our speakers to stay here, and we're going to have a question period after this. So I apologize that we don't have questions right now, but I promise that we will have an opportunity as soon as we are done. So thank you very much, Margie, for setting the stage. Now, our next speaker is Jean-Patrice Baillargeon from Universite de Sherbrooke. Sorry for the pronunciation. My kids make fun of my French accent all the time. And he's going to speak to us about the preconception period. So welcome to the stage.
I don't think it's a good presentation. Do we have the right slides?
We're looking for the preconception
So
slide.
do we have a IT tech? So thank you, Christy. In the meantime, so I'm endocrinologist and I'm clinical investigator at Universite de Sherbrooke, and I'm very delighted to be here to talk about a project and a subject that is very important to me, and hopefully,
He's going to find the slides here. Can you dance?
so anyway, so I will discuss about preconception. So we heard about prenatal physical activity, but my interest is really into the preconception management of obesity and how it relates to improving fertility as well as the health of the pregnancy and the newborn. So I have no disclosure for this presentation. You already have the objective in your package, and we'll start with the first slide. Oops, not good timing. I was hoping for the perfect right timing. So in the first slides, my objective was to convince you that obesity, in fact, is bad for your fertility. So that's the idea. First thing I would like to convince you to discuss. And maybe we should start with a definition of infertility. So infertility is very frequent. In fact, it affects 10 to 15% of couples in Canada. So it's something that we should be caring for. So obesity is probably bad for your fertility. So we'll discuss that. So the definition of infertility is the failure to achieve a clinical pregnancy after 12 months or more of regular unprotected sexual intercourse. And as I said, it's frequent, 10 to 15% of couples. And fertility has many causes. You see a lot of them on this slide. Some of the causes are modifiable, and you see, for example, polycystic ovary syndrome, other ovulatory disorders, and hormonal disorders. And I just realized that that's not my new slides, but that's okay. we'll manage. Those modifiable and endocrine disorders are one of the main causes of infertility. But what is less known is that obesity is also an important cause of infertility and is associated with infertility, and we'll discuss that. Obesity can cause infertility through polycystic ovary syndrome and probably also through other ovulatory or hormonal disorders. But obesity is also associated directly to infertility, and we'll discuss that. So, as you know, obesity is quite frequent in Canada. It's also highly prevalent in women in their reproductive age. So our census have shown that 24% of Canadian women aged between 20 and 44 years old are overweight, and 21% of them are obese. Because of that, women are more likely to enter pregnancy overweight or obese these days. And this is an example of a study made in the United States showing that 20% of women who delivered in the States were obese pre-pregnancy. So it's about the same numbers. So obesity is associated with fertility, and the following slides will show that in the more general population. But as I mentioned, it's also related to infertility directly without the effect of PCOS or anovulation. So if we look only to women with ovulatory cycles who have at least one pattern tube, so they look normal, they don't seem to have any specific infertility causes. And this study looked at 3,000 subfertile couples with those characteristics. And in fact, they showed that for every BMI point between 30 and 35, there was a 4% drop in conception rates within a year in these ovulatory, apparently normal women. So obesity seems to be related to fertility directly. And this is a large cohort, the Danish National Birth Cohort, looking at pregnant couples for whom we had reported BMI and time to pregnancy. So the table shows adjusted odds ratio for a time to pregnancy of 12 months or more, which is the definition of infertility. And as you can see, women who were obese had an increased odds of infertility of 78%. And overweight was also increased with a significant increase of infertility. So the odds were increased by 27%. You also see in that table that if the spouse is obese, the odds of infertility of the couples was increased by 49%. And if both spouses are obese, in fact, the effect is more than additive. The infertility is increased by 174%. So obesity, both in male and female, is associated with infertility. So that didn't work very well. It was looking good on the the pre-slides. So anyway, so we've shown that. All right, obesity is associated with infertility in women. It's also associated, and I won't show all the studies, but as will been shown that it's associated with a reduction in the efficacy of fertility treatments, an increase in the cost also of fertility treatments. But it's also important to consider that obesity during pregnancy is associated with a lot of complications, and Margie has discussed some of them. So obese women during pregnancy have increased risk of thromboembolism, preeclampsia, gestational diabetes, hypertension, even death in utero, macrosomia, as discussed before, prematurity, etc. So it's important to prevent obesity or to manage for obesity before and during pregnancy to prevent those complications. And lastly, it's important to know that obesity of the mother during pregnancy is associated with complication for the offspring, neonatal complication, but also of increased risk of early development of obesity, diabetes, and cardiovascular diseases. And Margie has mentioned that. So that means that through those fetal programming mechanisms, such as epigenetic, for example, an obese woman who gave birth to a baby girl, this baby girl is more likely to become obese and to be obese during her pregnancies. So this leads to a vicious circle of obesity, and those mechanisms can contribute to that. So we think it's very important to intervene or to be aware of these vicious circles and try to intervene specifically during this period. So preconception is a key period to to improve fertility, prevent pregnancy complication, but also to break this vicious circle of obesity. So what can we do about it? So the question would be, is there any lifestyle intervention that can improve those complications prior to pregnancy, so during preconception, or is there any way to improve those complications? Most of the studies on lifestyle intervention were performed in women with PCOS, in fact. So we know in that population that weight loss with or without exercise is indeed effective to improve ovulation rates, to resume normal ovulatory cycles. It has also been shown in a recent study that management of lifestyle modification in infertile women with fertility before fertility treatments can even improve their live birth rates. And those studies have shown that a weight loss of only 5 to 10% is usually enough to achieve those benefits. So in PCOS women, with or without infertility, lifestyle intervention is recommended as the first-line intervention. But we don't have much studies in the general population of women with obesity and infertility, not specifically PCOS. There is one, this large study published in New England Journal of Medicine in 2016, the Netherland Lifestyle Program Randomized Controlled Trial. In that study, so it was 564 women randomized with infertility, BMI of 29 or more, and they were randomized to a 6-month lifestyle intervention prior to the treatment of their infertility or prompt fertility treatment. So the control group was able to start their fertility treatment right away. The lifestyle intervention in that study was monthly visits with coaches, and also they had 4 phone calls between the visits. Nutritional and exercise advices were provided by these coaches, and the intervention was based on motivational counseling with individualized goals. And in that study, 22% of the participants discontinued the intervention, which was during the first 6 months. And in those who completed, 43% lost at least 5% of their initial weight, which is good, and none of the control group women lost that amount of weight. And here are the results. So you have the intervention group on the left, control group on the right, the 2 columns, and you can see that the occurrence of a natural pregnancy was very much increased and significantly increased in the intervention group. So 26% of the women in the intervention group was conceived naturally as compared to 16% in the control group. And this was with the use of less frequently use of infertility treatments. So 63% of the intervention group used fertility treatments as compared to 81% in the control group, and that was significant. However, for the whole study, the primary outcome was vaginal birth of healthy singleton at term, and live birth rate was also another outcome that was not significantly improved by the intervention. In fact, was even slightly reduced in the intervention group. But natural pregnancy is still a very important outcome. So in summary, for that part, lifestyle modification in women with obesity and infertility is recommended by the main professional organization because it can improve fertility and there is no specific risk associated with that. And as shown, it might improve natural conception. But there are still very few trials, in fact, assessing this approach as first-line therapy in women with infertility in general, not specifically in PCOS, and there's none in the Canadian context. So what do we do about that? So we've decided to perform a study, and we had support from CIHR and other organizations for the evaluation of clinical outcomes and costs of a transferable interdisciplinary lifestyle intervention in obese infertile women. So our hypothesis was that if we make available to women with obesity and infertility a program where they would be supported in order to adopt an healthy lifestyle during preconception, then that would improve their fertility, improve the efficacy of fertility treatments, and probably also improve the health of pregnancy and newborn. And that would lead to a decrease in cost for live birth, per live birth, the cost of fertility treatments, and the cost of complication during pregnancy and during the neonatal period. So we performed a randomized control trial in Sherbrooke that was completed, and we enrolled women with obesity or overweight if they had PCOS, who consulted to our fertility clinic. They were randomized to a control group who started their standard fertility care right away, such as in the study published in the New England, similar protocol, or they were randomized to the intervention. So we developed a lifestyle program that I will discuss at the next slide. We call it in French the Ferti Santé program. And those women had to postpone again their fertility treatments for the first 6 months, such as in the New England Journal paper study. But in our study, we decided to continue the lifestyle intervention during fertility treatments and also during pregnancy if they got pregnant. The intervention so lasts up to 18 months maximum or end of pregnancy. So the Ferti Santé program aimed to implement progressive and sustainable lifestyle changes. It was a low-intensity program, so there was some sense of urgency when you want to get pregnant. So many studies have implemented high-intensity lifestyle interventions, but we decided to use a low-intensity as the recommended guidelines. The components of our program first is individual meetings with a dietitian and a kinesiologist. So it was not only general counselors, advisors as compared to the New England Paper Journal program. We had professionals, and visits were every 6 weeks. We were based on motivational interviewing and SMART objectives. We also had a component of group sessions every week. We developed 12 different group sessions. The first part was a workshop on nutrition and psychology, and the second part was the demonstration of a physical activity. And we tried to involve the spouse as much as possible. We evaluate our clinical outcomes at 18 months or end of pregnancy, and these are the outcomes that were pertinent. And we've completed the study. So this is the flow chart. We randomized 130 women to both groups. We had 3 selection breaches. So the intent to treat analysis are on 63 women in the intervention group and 64 in the control group. We were very much interested also to look at 6 months. So those women who persisted at least 6 months, so who invested in the program, and we analyzed them as a modified per protocol analysis, and we had a 15% dropout at 6 months. And up to the end of the study, the dropout rate was 22.8%, similar to the Netherlands study. So I will not present the result now, because you will see them. Mattia Bellin will present that at the Pecha Kucha session just after, so stay here in the room, and you can discuss with Mattia at her poster board. But I have a spoiler very shortly. I'll let you know that we get important and very nice results. So in the modified per protocol analysis, we found that the intervention increased 2.7-fold the rate of spontaneous pregnancy in our research. And there was a trend for an improvement in live birth rate as opposed to the Netherlands program. It was not statistically significant because we probably lack power, but that was clinically significant. And rapidly, the intent to treat analysis also showed a significant improvement of spontaneous pregnancy rate and a trend for an increase in live birth rates. So the key messages for you today is that obesity management through lifestyle modification is feasible and effective in women with infertility and obesity, and interdisciplinary intervention supporting the adoption of healthy lifestyle in these women improve their fertility and mainly the occurrence of a spontaneous pregnancy. It decreases, accordingly, the need for expensive fertility treatments, so we think it's very important. And it is also expected that such approach could improve the health of the pregnancy, the newborn, and the future family, as Margie has so alluded to that. So we really think it's probably very important, maybe the best timing to intervene during preconception to improve all those consequences. And rapidly, following these important results, we receive funding for a Fit for Fertility multi-center randomized controlled trial where we will validate our results in 7 Canadian fertility centers throughout Canada, and Christy is collaborating to that important study. And stay tuned, we'll have the results in 4 years probably. So I would like to acknowledge my research group, my collaborators, and those who've done the work, mainly on that slides, as well as the participants to our study. Thank you very much.
Merci beaucoup, Jean-Patrice. Now, and thank you for accommodating the issues with our IT, and thank you to Dr. Shelley for running out there very quickly and helping out. So our next speaker that I'm pleased to introduce is Alena Puccini-Vallis, and she's from Dalhousie University, and I guess she'll tell you who she is specifically, and she's here to tell us about her work. Thank you.
Thank you, Christy. So yeah, I'm Alena Puccini-Vallis. I'm associate professor at Dalhousie University. And I'm here partly to represent a group of us who are currently developing guidelines for the management of weight gain in pregnancy, specifically for women with obesity. And so I'd like to acknowledge Christy, she's everywhere, and Rhonda Bell from the University of Alberta, and Karen Nierenberg, and also Leticia Perez, who's a PhD student from Brazil. So I recognize some of the Brazilian contingent here. Thank you for coming. So I have just one disclosure to make. So management of weight gain during pregnancy for women with obesity. Let me just reorient you, because Margie actually went over some of this, but the most recent guidelines for optimal weight gain during pregnancy take into account a woman's pre-pregnancy BMI. And as you can see here, the higher the pre-pregnancy BMI, the less amount of weight a woman should gain, which is a little bit of an issue for women with obesity, because you can see that their target weight gain is only 5 to 9 kilos. And when you take into account the weight of the baby, the placenta, the uterine muscle, etc., which amount to, at least 8 kilograms, it's a wonder that they actually can meet these targets at all. And in fact, only a minority of women have weight gain that is concordant with the guidelines. These are data from Nova Scotia, and as you can see there in the blue line, pretty consistently, only about 25 to 30% of women have weight gain that is concordant with the guidelines. But this is not broken down by pre-pregnancy BMI. So let's have a look at this with these 3 large trials, or actually studies, sorry, they're not trials. The first one is a Canadian study. The second one is a Norwegian prospective cohort study, quite impressive. And the third one is a study from the US. The blue bar represents women with overweight, and the gray bar represents women with obesity. And you can see across the studies that women with obesity are consistently pretty much on par with women with overweight in terms of guideline concordant gestational weight gain. But let's flip this around and look at guideline discordant weight gain. So this time, same 3 studies, this time the 2 bars on the left represent insufficient weight gain, and the 2 bars on the right represent excess weight gain. You can see across the 3 studies that women with obesity consistently more frequently gain insufficient weight gain and less frequently gain excess weight during pregnancy. And these are pretty statistically significantly different. And let's also remember that we're not comparing apples to apples here. So in order for a woman with overweight to have excess weight gain, she has to exceed 11.5 kilos. But for women with obesity, they only have to exceed 9 kilos. So what does this all mean? I mean, when we look at real numbers here, again, data from Nova Scotia, this is something that we published a few years ago. As you can see in the purple line there, which represents the gestational weight gain trajectory for women with obesity, they gain significantly less weight than their leaner counterparts. So the good news is that women with obesity gain less weight than everybody else, but the bad news is that a lot of these women are still gaining too much weight. And as Margie pointed out earlier, the concern that we have here is that guideline discordant weight gain is associated with many adverse outcomes for women and their children, both in the short and the long term. Now, there are a number of factors that influence the amount of weight that a woman gains, and I'd like for you all to keep in mind during my presentation that for women, the number one priority for them is the health of their baby. That's universal. And so when we think about the factors that influence gestational weight gain, it's really important to keep that in mind. So health behaviors, and we typically think of nutrition, physical activity as health behaviors that can influence gestational weight gain. But health beliefs are also really critical. These are powerful, powerful beliefs that come from a woman's culture, her community, and from advice that a woman receives from so many sources, the internet, family, friends, and clinicians. And we know that advice from clinicians actually has a big impact on a person's likelihood to initiate health behavior. This was a systematic review and meta-analysis that shows the odd ratio. They're huge odd ratios. Now, a good way to initiate a conversation and maintain a conversation going about gestational weight gain is to use an approach like the 5 A's of healthy pregnancy weight gain. This is a tool that we developed, actually Christy and I were part of the group that developed this tool. And it's based on principles of behavior change science and patient-centeredness. It was actually launched in 2014, and of course was an adaptation of the 5 A's of obesity management. And the first A is about asking permission to discuss gestational weight gain. The reason for this is that this is a respectful gesture. When you think about all the bias that's inherent in obesity, asking permission to have a conversation about weight is a respectful way to start things off. And also, like it or not, there is a, at least patient-perceived power differential between the clinician and the patient. And asking permission to start a conversation about something that's very sensitive kind of reduces that power differential a little bit. And we know that asking permission emphasizes patient-centeredness, and there's tons of work out there that shows that that's associated with an increase in the quality of the clinical encounter and a number of positive outcomes. But unfortunately, clinicians do not often initiate discussions about weight gain, even though patients really want them to talk about it. The second A is about assessing the patient's context. This is an opportunity for the clinician to ask questions about the woman's experience of gestational weight gain and understanding what her context is. Now, a behavior change psychologist that I know rather well has taught me to ask the learners who come to my clinic to try to go into an encounter and only ask questions, make no statements. That's not an easy thing to do, but it's a great way to learn about the patient in front of you. And when we consider the complexity in the etiology, multifaceted etiology of weight-related matters, and remember that for women, the number one priority is the health of their baby, it's really critical that a clinician explore a woman's cultural health beliefs. What about food security? Does she feel safe? Does she have social support? What about her mental health? So it's really important to do a comprehensive assessment. And I found this quote actually in the literature. This is actually a Canadian researcher that I thought really illustrated this point very well. I find they, healthcare professionals, do a whole lot of talking about us, how much we gain weight and gestational diabetes and blah, blah, blah. But they never focus any of their care around us and our culture or our communities. So if they want to fix the problems, they need to at least acknowledge our background in order to provide culturally sound care. To where we'll feel comfortable and want to work out and want to feel healthy instead of feeling ostracized. And here's some other quotes, too. The family members most frequently mentioned were mothers-in-law, as well as aunts, husbands, and boyfriends. While the specific advice varied, the major thing that emerged was that pregnant women should be eating for two. We've all heard this, but it's very important that a clinician find out that that's important for the women in front of him or her. Because without this knowledge, how can you possibly provide meaningful advice? When you're pregnant, I think family pushes you more. They think the fatter you get, the healthier the baby is. Again, a common health belief, but it's really important for the clinician to know that for the woman in front of them, that's a health belief. I'd rather get big myself and have a healthy baby rather than stay slim and end up having a little 6-pounder who wasn't as healthy. So I tend to push all my feelings aside about my weight because I know that I'm going to end up having a healthy child because of it. So I can worry about myself after I give birth. This points actually to a common belief that women have that they're mortified of gaining insufficient weight. To them, that's the worst thing they could do. So they tend to gravitate towards excess weight gain. And it's important for the clinician to know that. Otherwise, how can you have a meaningful conversation? So then the advice piece should be based, so what we advise patients should be based on our assessment. And it's an opportunity for us to make evidence-based, contextual gestational recommendations that are relevant to women with obesity and invite them to discuss things like general advice about gestational weight gain, metformin prescription, nutrition advice, physical activity advice, and comprehensive lifestyle interventions. So I'm going to go through these. Wrong way. So general advice about gestational weight gain, we've touched on this already. For women with obesity, the target weight gain is 5 to 9 kilos over the entire pregnancy and around 0.2 kilograms per week in the second and third trimesters. As far as metformin prescription, there was a randomized controlled trial published in 2015 in which 449 women were randomized to either metformin up to 2,500 milligrams a day or placebo. And at delivery, there was no significant difference in the gestational weight gain. A recent Cochrane review concluded that women with obesity who receive metformin may have a slightly lower gestational weight gain. So at the moment, we're recommending that metformin should not be used for the purpose of managing gestational weight gain in women with obesity. Nutrition advice, well, there are a lot of sources that tell us slightly different things, and I'm not a nutritionist, a dietitian, but the general recommendation is that during the second trimester, women should consume an extra 300 to 350 calories a day, and during the third trimester, that should go up to maybe as high as an extra 450 calories a day, but there's a little bit of variability in the recommendations. And for women with obesity specifically, the recommendation is that they maybe should be eating a little bit less. Also, not a lot is known about the relationship of specific dietary components with gestational weight gain, but what we do know is that cultural beliefs play a huge role. And we also know, this was a study from the University of Alberta, actually, Rhonda Bell's camp, that women with obesity tend to have lower adherence to the Canada Food Guide and higher what they called less healthy scores. So in their study, they observed that women with obesity tended to consume more often less healthy foods than their leaner counterparts. And here's just an example of a trial that was done in which 50 women with obesity were assigned to either usual care or intervention. This was a Danish study. And the intervention consisted of 10 one-hour sessions with a dietitian in which they reviewed the Danish food guide, and women kept a diary, and the women received feedback on their food diary. And at 36 weeks gestation, the intervention group had a significantly lower gestational weight gain than the control group. There are lots of trials out there. I'm just sort of flashing through these, but the bottom line is that prenatal care providers should encourage and support pregnant women with obesity to consume foods consistent with a healthy dietary pattern in order to meet their target gestational weight gain. And encouraging and supporting requires requires the clinician to have understood the woman's context. As far as physical activity advice, I'm barely going to touch on this because you've already heard from the expert in the group. I'd like to acknowledge the people in the audience who, and here at the front, who've contributed to these guidelines, and we're not going to disagree with them. Prenatal care providers should encourage and support pregnant women with obesity who do not have contraindications to exercise during pregnancy to engage in at least 150 minutes per week of moderate intensity physical activity to assist in the management of gestational weight gain. How did we do? But I'd like to add something to that, and that is that when looking for context, again, it's really important for the provider to understand for that specific woman, the individual woman, what are her reasons for not being physically active? So what are the advantages to her of not engaging in physical activity? Or another way to look at it is, what are the disadvantages of becoming physically active? Because there must be some, otherwise they'd all be physically active. So again, what are her cultural health beliefs? What about her sense of safety, and does she have social support to become physically active? Now I'd like to just show you a brief video that we developed to illustrate some of these points. You know, the weaving in and out of asking, advise, and assist. And I'm not going to show it all because it's kind of long.
Hey Jen, so everything seems to be going really well. You're at 28 weeks, your baby seems to be moving around okay and growing well, your blood pressure is good. The only thing is, has anybody ever talked to you about what would be a healthy weight gain for you during your pregnancy?
No, nobody has.
And would it be okay for us to talk about that today?
Sure.
Okay. So based on your height and how much you weigh before your pregnancy, we know that you should probably be
Okay, so you get the idea. Finally, as comprehensive lifestyle interventions, there are many trials out there that show that a combination of nutritional advice, and physical activity have a significant impact on gestational weight gain. And so our recommendation as a group is that prenatal care providers should offer lifestyle interventions, including both nutrition and physical activity, to pregnant women with obesity. What about other recommendations? I mean, the impact of sleep on gestational weight gain is really interesting and is an up-and-coming field. The question about weight loss for women with obesity is also still a little controversial. And I went to the keynote address on Tuesday evening, and what about the effect of eliminating consumption of ultra-processed foods? That sounds like a really interesting area as well. But in conclusion, when we consider the multifaceted and complex etiology of weight, and prenatal care providers should be non-judgmentally curious, explore the woman's experience of gestational weight gain, understand the woman's proximal and distal contexts, and make evidence-based recommendations that are meaningful to the individual woman and find common ground. And I'd like to leave you with this quote that I think summarizes it all. She, the healthcare provider, should have asked me how I felt about my weight gain, not just told me how she felt about it. These are my references. Thank you very much.
So I'm going to take a lesson, and I'm going to do the 5 A's of chairing. I'm going to ask you if you have questions, but assessing things, we only have a few minutes, so I'd advise you to maybe keep it short, and we'll maybe go a few minutes over into the Pecha Kucha, so please stick around if we have questions. There's microphones on the sides.
I have a question here, not really directed to anyone in particular, but maybe Dr. Vallis or Margie or Dr. Baillargeon. A question is, well, this is theoretically awesome work, and I've been involved with some of it and happy to see it's coming into the clinical sphere as a new OBGYN looking to optimize my training during residency. The time requirements that are put on us for the clinical encounter are not something that I take lightly. We are forced to do a high patient load. We have about 5 minutes per patient, 60 patients per day. How do you suggest my colleagues and I tackle this complex area for the patient benefit and for the health of the children and mom?
Yeah, that's a very, we frequently hear that question. So one of the key pieces of advice is use the time you have. But I guess more specifically, during pregnancy, providers see women for a number of occasions. So there, I don't know, 13, 14 visits if somebody actually adheres to the recommendations of, every 4 weeks until 28 weeks, and then every 2 weeks, and then every week till delivery. So a provider will see a woman many times during her pregnancy. So there are lots of opportunities to get the conversation going, get the conversation started. You don't have to go through it all the first time, right? And so as you get to know the woman and get to know her context, get to know the whole person, develop a relationship, those conversations flow a little bit more easily. I have that experience as a family physician. I know my patients fairly well. So yeah, it's just not something that has to happen all at once at the first visit. Does that help?
I'll, of course, follow-ups after during our networking session. We'll have the one last question to my right here.
Thank you for the amazing presentations. I have a question for Dr. Davenport. Have you considered utilizing the partners or the spouses in the exercise program as a motivator for increasing the activity? It will not only improve the skeletal muscle, but also enhance the emotional muscle. Adding, 2 people in the one program, improving the health of 2, or in fact 3 people, not only the child, the mother, and the spouse. Also, it'll benefit in terms of developing or keeping the romance alive. It teaches them empathy, as well as engaging them for a much longer period of time.
Yeah, absolutely. Certainly, there are a number of groups that have been trying to include the partner, the spouse. Dr. Matola has done some work in this. I believe you are as well. And I believe that, you know, there's sort of a varying effectiveness in including the partner. If you have an engaged and interested partner, then it's going to be by far the most effective. Having that social support is really critical during pregnancy, but we also find that it's not always necessarily effective. The partner isn't always as engaged, at least in physical activity, unfortunately.
Thank you.
All right,
So-
well, please join me. Or you, sorry,
Oh,
go
yeah,
ahead, please,
I was just about to say we also try to involve the spouse as much as possible in our preconception study. And it was difficult to have the spouse at the meeting during the day, but the group session in the evening where they were more likely to come. And we also had the idea that if we improve the lifestyle of the woman, would it help for the husband to change his lifestyle in the same time? And so far, the results are not very good, so it seems that it's not enough. We really have to implicate the spouse in the intervention, so to meet with him and have him implicated more than just by the change that the women will do.
All right, well, join me in thanking our speakers, and thank you for attending the session. And now it's Pecha Kucha time.
That was great. I learned a lot from both guys. That was awesome.
At this time, I would like to invite the Pecha Kucha participants to come up to the front. Yeah, I just want to review the rules with you all. I guess I can start, right? Christy, are you ready? You guys ready? No, I'm ready. We're good? So good morning, everyone. My name is Stephanie Peplinski, and I am on the SNP committee, and I am the lucky person who gets to introduce our fabulous Pecha Kucha presenters this morning. For those of you who are unfamiliar, Pecha Kucha is a unique style of presentation where each presenter has 20 slides that they will present to you, and each slide is only allotted 20 seconds. So the idea is it's going to be quick, it's going to be fun, and if you have any questions for the presenters, you may ask them at their poster presentations following this section. So without further ado, I would like to introduce our first presenter, Tanya Nagpal from the University of Western Ontario, and she will be presenting and asking the question, does weight loss prior to pregnancy impact gestational weight gain and adherence to nutrition and exercise recommendations during pregnancy?
Are we ready for this? Is this the right time? Can we handle this? Stressful questions like these may be crossing someone's mind when they're making that big decision to start trying to have a family. Now imagine having to make that same decision and being informed by your healthcare provider that due to your weight, it might be difficult for you to conceive. As the prevalence of obesity continues to increase, this might be a real conversation for more women. Specifically, current statistics show us that 1 in 6 pregnant women enter pregnancy with a pre-pregnancy BMI greater than 25. And as I mentioned, these numbers continue to increase. Now, an elevated BMI is associated with infertility, but also pregnancy complications, including preterm delivery, baby being born too early, gestational diabetes and hypertension, that is the onset of diabetes and high blood pressure during pregnancy, and even poor placental function. In addition to these complications, we also see that women may be at greater risk for excessive gestational weight gain. That is, gaining above the recommended guidelines according to pre-pregnancy BMI for weight during pregnancy. Now, gaining excessively actually further increases the risks for the complications I just presented, but also we see a link between the future risk of obesity, and again, impacting both mom and baby. Specifically, babies may be more likely to be born large for gestational age, and this could lead to both childhood and adulthood obesity. And moms may carry extra weight into the postpartum period, leading to postpartum weight retention that may be difficult to lose. So, is there anything we can do to prevent excessive gestational weight gain? The answer is yes. Research has shown time and time again, offering women a lifestyle intervention, including both nutrition and physical activity, can help prevent excessive weight gain and promote an appropriate amount of gestational weight gain. And this is true regardless of pre-pregnancy BMI, meaning we can offer a lifestyle intervention to all women. So what is currently being done? Well, currently, we see that women who seek preconception counseling with an elevated BMI may be told that it might be helpful to lose weight in order to improve fertility. As well, we see that entering pregnancy with a lower BMI reduces your risk of pregnancy-related complications. Now, don't get me wrong, this is literature supported. We do in fact see losing weight does improve your chances of fertility. As well, entering pregnancy with a lower BMI does indeed have a lower risk for complications. So what's the missing puzzle piece here? Well, there's a little bridge that's missing. We don't know yet if weight loss behaviors before pregnancy impact weight gain during pregnancy. And that's where this research question comes into play. We want to know women who experience weight fluctuations prior to pregnancy, what does that do to their adherence to both nutrition and exercise once they are pregnant? As well, is there a link between excessive gestational weight gain and weight fluctuations experienced before pregnancy? And that's where our research comes in. We took a look at a nutrition and exercise program offered to women with a BMI over 25. They began the program at 12 to 18 weeks pregnant, and we followed them all the way up until delivery, tracking their weight gain. They followed both nutrition and exercise behaviors, and in the end, we saw if they gained excessively or appropriately. Before beginning, they completed a weight and health history questionnaire. This questionnaire assessed demographic information, but we also asked them, were you trying to lose weight before this pregnancy? And if yes, how much weight did you actually lose? After they completed this questionnaire, they were on their way on the NELIP program. The program included 3 goals for nutrition. This was tracking your weekly food intake, aiming for 2,000 calories per day and 200 to 250 grams of carbs per day, designed to assure women meet the macronutrient requirements during pregnancy and also promoting an appropriate amount of gestational weight gain. In addition to this, they had 3 exercise goals. This included attending 1 weekly supervised walking session in the lab and then walking a second and third time on their own for a total of 3 walking sessions at least every week. These sessions started at 25 minutes, and we added 2 minutes every week until eventually women were walking for 40-minute sessions. So altogether, they had 6 goals for adherence, which translated into 6 points, and we gave them an average adherence score at the end of the program out of 6, and we had their responses from the Weight and Health History questionnaire. We grouped the women as gained excessively and appropriately at the end and compared both adherence and the responses from the Weight and Health History questionnaire between our 2 groups. And here are our results. We saw that in terms of demographics, age, parity, pre-pregnancy BMI, there was no difference between the 53 women who gained appropriately and the 47 who gained excessively. Taking a look at adherence, highlighted in the pink for excessive women, we see that women who gained excessively had lower program adherence than those women who gained appropriately. We also see that those women who gained excessively, more in that category, 63% said, yes, I was trying to lose weight, compared to only 40% in the appropriate group. Both groups had women trying to lose weight, but the women who gained excessively lost significantly more weight. I'd like to repeat these results for you one more time. So women who gained excessively had lower program adherence to the program than women who gained appropriately. In both groups, we saw women were trying to lose weight, more in the excessive group. However, the women who gained excessively lost significantly more weight than those women who gained appropriately. So what does this all mean? Well, we've shown some patterns. We've shown that between women who gain excessively and appropriately, there is a difference in their adherence to nutrition and exercise. There may be a difference in their trying to lose weight, but also the amount of weight they lose immediately before pregnancy. And hopefully what this does is perpetuate further research in this area to connect the dots between preconception behaviors and what happens during pregnancy. So we've asked an important novel research question, and we used an adherence measurement tool that incorporated both nutrition and exercise. However, we did use a self-reported questionnaire and a convenience sample. So future studies should aim to follow women in that preconception period into pregnancy, looking at correlations, but I'd like to take that one step further and suggest future studies should aim to support women with a healthy lifestyle before pregnancy and during. And this may improve the health and well-being of 2 generations, both mom and baby. Thank you.
Thank you, Tanya. Up next, we have Alena from Dalhousie University, and her topic, the association between women's gestational weight gain, concordance with guidelines, and their children's body mass index trajectories.
I'm back. Yes, my study entitled The Association Between Women's Gestational Weight Gain Concordance with Guidelines and Their Children's Body Mass Index Trajectories is actually in partial fulfillment of the requirements for my PhD in family medicine at Western University, and hence the logos. As background, the most recent guidelines for optimal weight gain during pregnancy take into account a woman's pre-pregnancy BMI. The higher the pre-pregnancy BMI, the lower the amount of weight that should be gained, which is problematic for women with higher BMIs because they typically have trouble managing their weight in the first place. And in fact, most women have guideline discordant gestational weight gain. Guideline data here from Nova Scotia show about 60% of women gain too much weight and around 15% of women gain too little weight. And guideline discordant gestational weight gain is associated with a number of adverse outcomes for moms and their kids, including downstream childhood obesity. So the rationale for my study was that in Nova Scotia, about 75% of women experience guideline discordant gestational weight gain, and 15% of women, children in grade 3 have obesity. While excess gestational weight gain has been linked to childhood obesity, the data have mostly not been longitudinal and not based in primary care. So my research question is, do mothers with total gestational weight gain at term that is above, within, or below guideline recommended amounts deliver children whose BMIs are different over time, i.e. measured multiple times up to approximately 5 years of age, controlling for maternal age, parity, smoking, SES, and the child's sex? This was a retrospective cohort study with data from 2 sources. Number 1, women who received prenatal care at Dalhousie University between January 1st, 2010 and December 31st, 2017. And 2, children who received well child care at Dalhousie Family Medicine between those 2 dates. The data came from our EMR, and were contained in two smart forms inside the EMR. Number one, the prenatal record, which is where the data from the women came, and number two, the Rourke baby record, where the data from for the children came, which is typically used by most providers across the country. Linking the mothers and their children was done via the 10-digit telephone number. I used a deterministic linkage approach, meaning that the phone numbers had to match exactly. And I had done some previous work on this in a random sample of 25 women and 25 children, showing that the specificity and sensitivity were pretty high. The first thing that I had to do was data cleaning. The data were exported into an Excel spreadsheet with unidentifiable column headers and inconsistent data entries. So a child's weight could have been 3,000 kg, 3,000 G, 3,000 grams, 3.0 kg, you get the idea. After I had all my inclusion and exclusion criteria, and one of those was that women could only be linked up with one child, so there were no multiple pregnancies, and no gestational diabetes, all that sort of stuff. I ended up with 304 unique mother-child dyads and 2,402 data points. So this is a conceptualization of my study. I'm looking at women who gained weight above, within, and below the guidelines and their children's BMI trajectories over time. The Rourke baby record has data entry points at 13 different times. For example, the 1-year mark. And so these are the 13 times. Let's zoom into the 1-year time point there. And very few parents bring their children in at exactly 365 days of age. It could be 340, 390. So for each of these categories, there was going to be a whole lot of heterogeneity in terms of the child's age. So I approached age as days. But if you can imagine an Excel spreadsheet with each row representing a child and 2,000 columns, because 5 years of age is about 2,000 days, there was going to be a ton of missing data, which was giving me a bit of a headache for data analysis. But fortunately, under the umbrella of growth modeling, multi-level modeling is actually perfect for my situation because it accommodates participants who have randomly missing data and data that's collected at different intervals. And it models different patterns of change as well. So my data are organized like this, repeated BMI measures nested within the child. And here are my results. So the mean age for moms was 29 years, and the rest of the frequencies and means are pretty much typical of what you'd see in the literature. So the pre-pregnancy BMI category distribution, a lot of women had excess weight. Most women claimed to not smoke during pregnancy. Most women were nulliparous. There are slightly more boys than girls. Mean birth weight was just over 3,500 grams. And the pièce de résistance here, the gestational weight gain concordance, most women gained weight above the guidelines and only a few gained weight below the guidelines. And here are the line plots for the children. So the top left represents the BMI trajectories for all the children. On the top right is the BMI trajectories for children whose moms gained below the guidelines. And then bottom left, the children whose moms gained within the guidelines, and the last one is children whose moms gained above the guidelines. A mixed model allowing for quadratic distribution was significantly better than a linear model, which isn't surprising. This is not a straight line. But also a mixed model allowing for cubic distributions was significantly better than the quadratic model. Again, not surprising, having seen the plots. And this is where I wish I had more than 20 seconds. The bottom line is the children whose mothers gained below the guidelines had significantly lighter BMIs than children whose mothers gained above the guidelines, up to about 10 months of age, when they converged, and then there was a switch. So this study adds to the understanding of how pregnancy weight gain affects downstream childhood weight. It actually complements other work that I found out just recently is currently going on in Canada, which is really exciting. And it's potentially useful information for parents and primary care providers. Thank you.
Thank you, Alena. Our third presenter also comes from Western University. Karishma Hossain will be presenting on strategies for healthy lifestyle during pregnancy and asking, can we prevent excessive gestational weight gain?
Have you ever tried to start a healthy eating intervention? Or have you ever started a new exercise program? Did you do it to try to lose weight or to prevent chronic disease? Well, for pregnant women and for non-pregnant populations, just like non-pregnant populations, healthy exercise and nutrition are important for controlling weight gain. The global pandemic of obesity affects everyone, even women who become pregnant. In fact, entering pregnancy with obesity can lead to several adverse outcomes for both mom and baby, like preterm birth or C-section, especially if mom also gains excessive weight during her pregnancy. Excessive gestational weight gain can be defined as any weight that is gained over what is recommended for women based on her pre-pregnancy BMI. For example, a woman with obesity should be gaining between 11 and 20 pounds or 5 to 9 kilograms over the course of her pregnancy. This recommended weight accounts for the weight of the fetus, the uterus, the placenta, the amniotic fluid, and any increased maternal blood volume. If excessive weight is gained during pregnancy, it will work to perpetuate the cycle of obesity, which can affect the mother, her child, and subsequent generations, as seen on the left. But, as we can see on the right, if a healthy lifestyle intervention is used, the cycle can be broken, thus reducing chronic disease risk for the mother and for future generations. In my lab at Western University, we use the Nutrition and Exercise Lifestyle Intervention Program, or NELIP. It is a healthy behavior change intervention that focuses on two components, nutrition and exercise, presented either simultaneously or sequentially, to promote appropriate weight gain during pregnancy based on a woman's pre-pregnancy BMI. So we know that effective behavior change strategies may help to improve implementation of interventions to make healthy lifestyle behaviors easier. So considering that, what strategies can be employed for successful behavior change during pregnancy, and which of these strategies might be most effective at preventing excessive gestational weight gain? For this study, we hypothesized that delivering nutrition and exercise components sequentially might be more effective than introducing them simultaneously. As such, we created 3 intervention strategy groups that we randomized women to. Group A received both behaviors simultaneously. Group B started with nutrition first and had exercise added later, and Group C started with exercise first and had nutrition added later. The nutrition component of the NELIP was based on the modified gestational diabetic diet. Women were asked to consume around 2,000 calories per day, and through 3 meals and 3 to 4 snacks per day, to achieve around 200 to 250 grams of carbohydrates per day. We measured this intake via a food intake record. The exercise component of the NELIP involved a moderate intensity activity, which was simply walking. We chose moderate intensity because it would be easy for women of any physical activity status to adopt into their lifestyle, and walking is a cost-effective activity that can be done indoors or outdoors. For the exercise component, women were asked to complete 3 to 4 walks per week with one walk in the lab with us and another 2 or 3 walks on their own, starting at 25 minutes duration and increasing by 2 minutes per week to a maximum of 40 minutes per walk. Walks were tracked using exercise logs and step counts. To monitor their nutrition and physical activity habits, we presented women with a number of self-monitoring choices. To track step counts, we offered them either a pedometer to be worn at the hip or a physical activity tracker to be worn at the wrist. For food intake recording, they could use a food intake record done either on a paper log or an electronic log. So women entered the study in early pregnancy, between 12 to 18 weeks of gestation. They came to the lab weekly for face-to-face meetings, where they participated in an exercise session that was supervised, and they received nutritional counseling. Weight gain was assessed at these visits halfway through the pregnancy at 24 weeks gestation and toward the end of pregnancy at 36 weeks gestation. So what did we find? Well, we saw that the percent of excessive gestational weight gain was lower for Group C compared to the other groups, A and B. We also saw that Groups A and C had an increased frequency of physical activity from the start of pregnancy to the end of pregnancy. For nutrition, we didn't see any differences in nutrient intake, but we did see that there were trends towards women consuming too much fat and not enough protein. So again, for this small randomized controlled pilot study, we saw that the percent of excessive gestational weight gain for Group C, the group that started with exercise and then had nutrition sequentially added halfway through, was significantly lower than the percent of excessive gestational weight gain for the other 2 groups, Groups A and B. So to recap, we had Group A starting nutrition and exercise simultaneously at study entry, Group B starting with nutrition and then having exercise sequentially added halfway through, Group C starting with exercise and having nutrition added halfway through. So overall from this, we concluded that sequential introduction of behavior change might be easiest for pregnant women, and the Group C, the Exercise First strategy, was suggested. We also concluded that perhaps nutrition first programs might be too challenging. So for those strategies, we suggested that you should proceed with caution and consider that one size does not fit all when designing and prescribing healthy lifestyle interventions for pregnant women. This is particularly important to consider when prescribing lifestyle intervention for women who are entering pregnancy with obesity. We know that adopting a new or an improved lifestyle behavior can be challenging, especially if a woman struggled with the mastery of healthy lifestyle behaviors before becoming pregnant. That's why it is so important to choose an effective behavior change strategy to prevent excessive gestational weight gain. As the data from this pilot study suggest, exercise could be the gateway to other healthy lifestyle behaviors, like more consistent exercise, choosing nutritious eating habits, as well as improving mental and social well-being. And to stress this point even further, I'll leave you with this slide. The egg that formed you was created when your grandmother was pregnant with your mom. So this just goes to show even more that the importance of developing healthy nutrition and exercise behaviors during pregnancy is paramount, because healthy choices or health choices made during pregnancy can have an effect on 1, 2, and even 3 future generations. Thank you.
Thank you, Karishma. Our final presenter today is Matea Belan from the University of Sherbrooke, and her topic is a lifestyle management program targeting women with obesity and for infertility improves their chances of conceiving without fertility treatments.
So hello to everyone. I'm pretty excited to be the one repeating pretty much what my supervisor presented before. So just in case you missed something, here we go. So infertility is defined as the inability to conceive. Is it working or am I too fast? Oh, man. Oh, there you go. So infertility is defined as the inability to conceive after 12 months of regular and unprotected sexual relations. And it has become an increasing problem in our societies because its prevalence has almost doubled in the past 20 years or so, where now it affects 1 out of 6 couples in Canada. And several studies have reported on the risk factors of female infertility, and some of those risk factors are considered as non-modifiable, and others are. And one of those modifiable risk factors that caught our attention was that one of obesity. And so obesity was linked, as you maybe now know, to an increased risk of having the polycystic ovary syndrome, which is a syndrome that affects 6 to 10% of women of childbearing age. It is also associated to menstrual and ovulatory disorders, and it also decreases the effectiveness of medically assisted reproduction procedures, which are the fertility treatments. But the interesting part is because obesity is a modifiable risk factor, well, it is recommended as a first-line treatment that women with obesity and infertility change their lifestyle habits and maybe lose a moderate amount of weight before they begin their fertility treatment, as this improves their fertility. But despite the improvements, there are still very few randomized controlled trials on the subject. And so we decided to perform one on our own, which is the obesity fertility study, which wanted to assess the Fit for Fertility's program effects on live birth rate, pregnancy rate, and also the lifestyle habits and anthropometric measures. So we recruited all women that had infertility, that had a BMI above 30 or above 27 with the polycystic ovary syndrome, and also all women that were of childbearing age. We excluded all women that have already participated in other intensive lifestyle interventions, that had a severe infertility factor, female or male, or that had or were planning on having a bariatric surgery. We assessed these women at every 6 months up until 18 months, or if they became pregnant, then we saw them at the beginning of the pregnancy and at 26 weeks within their pregnancy, and we saw them to assess mainly anthropometric measures and lifestyle habits. So we had 130 women which were randomized. 65 of them were in the control group, so they followed the usual standard of care for infertility, so basically they followed their gynecologist recommendations, and we had 65 women which were randomized for the Fit for Fertility program. So the program had three main elements. First of all, they had individual sessions with a kinesiologist and a nutritionist. They had 12 mandatory group sessions, and they also had to stop or postpone the use of fertility treatments during the first 6 months of their participation to really appreciate the impacts of the intervention on their fertility outcome. So to go back to the flow chart, this is simply to show you that I'll be presenting results for women that have persevered at least 6 months into the study or became pregnant during their first 6 months of participation in the study. So you can see that we had a 15% dropout rate at this moment. So for the results, you can see for the anthropometric changes at 6 months, although the numbers are pretty low in both groups, you can still see that the intervention group has lost more weight, lost also more waist circumference and percentages of fat mass compared to the control group. You can see also that in the lifestyle changes at 6 months, so the intervention group has significantly and highly improved their nutritional quality. They also increased their daily energy expenditure during leisure activities. And also, interestingly, they pretty much decreased their time spent doing sedentary activities compared to the control group. So now for the fertility outcomes, for the pregnancy rate at 18 months, we had a pretty significant difference. So we had 61% pregnancy rate in the intervention group compared to 39% in the control group, and this was highly significant. But what is even more interesting is when we look at the spontaneous pregnancy rate, so pregnancies that occurred without the use of fertility treatments. So this time you can see that 1 out of 3 women in the intervention group became pregnant without using fertility treatments compared to 1 out of 10 in the control group, and this was highly significant. So pregnancies are fun, but live births are even more so. So when we look at our primary outcome, which was the live birth rate at 18 months, we had 51% live birth rate in the intervention group compared to around 37% in the control group. And this difference, around 14% between both groups, was not statistically significant, but it was clinically. So this slide is only to show you that the pregnancy rate over time is different between both groups. So it's pretty stable or even increases through time in the intervention group compared to a pretty drastic decrease over time in the control group. And the final slide for the results is only to show you that we did also the intention to treat analysis. And you can see that although the results are diluted, we still had a very significant difference between both groups for the spontaneous pregnancy rate, which was pretty much higher in the intervention group compared to the control group. So my take-home message today is that a lifestyle intervention targeting women with obesity and infertility improves their chances of conceiving, especially spontaneously. And this mainly occurs because of lifestyle changes and maybe not so much because of a weight loss. And all of this could help in decreasing the costs associated to the fertility treatments in this population. So there's a lot of people I would like to thank who participated and also helped us to the study. I would like to thank my supervisor and also you for your attention today. And it's done.
Thank you, Matea. On that note, let's give our 4 presenters today a big round of applause. They did wonderful. Thank you, delegates, for your time as well, and for the audience for your attention. As a reminder, there is no questions now. However, if you'd like to go onto the app and rate each presenter on what they presented today, that would be great. And if you have further questions, you may head to their poster presentations in the main lobby. On that note, I will dismiss this session, introduce lunch, and for those of you who are interested in starting a local chapter in your area, there is an information session in Les Saisons beginning right now as well. Thank you.